Hello, welcome back to the second episode of Vulva Talk. I
Yay!
am Dr. Margaret Cox, broadcasting from the University of Utah in the great city of Salt Lake City.
And I am Dr. Kylie Mox, broadcasting from Baltimore, but I work at the Centers for Vulvovaginal Disorders in DC, where I'm a gynecologist. And we are so excited because we got 26 whole listens of the podcast, so there's nowhere to go but up on our first episode. Hooray!
Pretty good,
We're,
pretty good. We hope you
we're,
found the information useful and entertaining,
yeah,
informative above all. So I
we're
do
not
want
in
to
it for the
caveat.
fame.
I do want to caveat with this is not medical advice. It's just for general information and knowledge only. If you are having any issues related to the things we talk about, please see your doctor for personalized medical advice. Always good to start off on that note. Okay, today we are talking about some very exciting things. As previously, we're going to do 3 kind of mini sessions, starting off with a pop culture trend, or is like a trend. It's a trend. A
Yeah,
trend.
yeah.
And the
Item of
trend
interest.
is, what is the trend, Kylie?
The trend is, should you be putting estrogen on the skin other than, for example, the vagina or the vestibule at the entrance of the vulva? And this is a hot topic. I've seen it a number of times. I've had patients ask me about it, and I'm so curious about your take on it.
Okay, so yes, is topical estrogen useful for aging skin? I mean, I think that's the ultimate question here.
Yes.
And this is a topic that has been around for a while. I mean, I want to start off by saying that yes, skin is an estrogen dependent organ. So we know that while people who are making estrogen in their ovaries, while they're making estrogen, their skin is nice and supple and youthful because there's receptors in the skin that estrogen binds to. And it makes it feel like that. So when we have decreased estrogen levels, when we're going through menopause or perimenopause, there can be changes in the way the skin looks and the way the skin feels. And we know that this happens because if we sort of do a biopsy of skin in the post menopause, we know that there's a decrease in the collagen fibers that are present there, and there's a decrease in blood vessels. There's a decrease in skin thickness. So this is a estrogen dependent organ. So technically, theoretically, if we think about it this way, the question is, if we put estrogen back onto the skin, are we going to get back some of those effects that we have with loss of estrogen? There's a couple of studies that have looked at specifically whether topical estrogen helps with signs of skin aging. And the first one that I could find goes back to 1994. It was a pilot study that was published in this hilarious journal called Maturitas. I think that's the way you say it. It's the
Oh,
International
Maturitas?
Journal. Yeah, Maturitas. It's the International Journal of Midlife Health and Beyond. So they looked at 8 perimenopausal women and they treated them with 0.3% estriol cream. And
Okay.
then they had 10 patients who they treated with 0.01% estradiol cream for
Okay,
6 months. And they were
And so for
checking in
people who
monthly.
are Yeah, and for people who may not know, estriol is a much less potent form of estrogen
Right.
versus estradiol, which is sort of the normal, naturally occurring estrogen that your ovaries make. So
Right.
they
And I
did
think,
a higher concentration of the lower potency stuff and then a lower concentration of the higher potency stuff.
yeah. And I think this is a great study. I thought it was a reasonable study because they were looking at whether the topical estrogen on your face is going to have any systemic effects. And I think that's always a big question when we're putting estrogen anywhere on the skin.
Yes.
Is there going to be systemic absorption enough to the point where we're having systemic effects of increased estrogen? Mainly people are worried about things like breast cancer,
Endometrial cancer, breast cancer.
endometrial cancer,
Yeah.
cardiovascular risk, etc.
Can I just
So,
interject the
yeah,
OBGYN perspective, which is the lining of the uterus is dependent on estrogen to grow. And if it has enough estrogen that it can grow, it needs to have something so that it can shed. And you only make progesterone, which is the hormone that causes you to shed the lining of the uterus, if you are ovulating. And so if you don't ovulate because you're in postmenopause, but you still have estrogen to grow the lining of the uterus, eventually it can grow into something you don't want, like a precancer or a cancer, because it's not shedding regularly. So that the big concern for me as a gynecologist with people putting a bunch of estrogen on and having a higher systemic level is, could they get an endometrial cancer? And obviously
absolutely.
other estrogen mediated cancers like breast cancer. Yeah.
Absolutely. And so the people who put together this study had that concern as well. So they were checking systemic levels of prolactin, follicle stimulating hormone, and estradiol.
Because
They also
theoretically, if you have lots of estrogen, your follicle stimulating hormone will go down because it's sort of mimicking having a lot of estrogen, like when you're ovulating. And so that's the sign that your brain is sensing the amount of estrogen that's around.
So they were looking at those three specific levels in the blood, and then they also did gynecological exams throughout the study, and then they were questioning patients whether they had these climacteric symptoms like hot flashes, night sweats, vaginal dryness. They did breast exam, colposcopy exam, and pap smears, kind of semi-regularly throughout the 6-month period.
Stem to stern, yeah.
Sorry.
Stem to stern. They covered everything.
Yeah, they were in it, and so what they found was that both groups showed improvement in the skin, so diminished wrinkles, especially around the crow's feet area. And the estriol group was slightly superior in terms of how much improvement the objective reviewers of this appreciated, and how soon after starting treatment you were able to notice these differences. And then importantly, they did not report any hormonal side effects based on clinic or lab review. So there were no changes pre and post the application of this topical estrogen. And I do want to add that the patients were putting on a very high amount of estrogen. They were doing a gram on their face and neck.
Yeah, that's a lot.
Which is a ton. It's a ton. Normally you would be doing like a pea-size amount, which is going to be not
quarter of a gram or a half a gram. Yeah.
Yeah. Probably less than half a gram. So they were doing a pretty significant amount on the head and neck. And despite that, there were no serologic differences before and after. This group did do a follow-up study a couple of years later, which looked at a larger cohort of patients. And again, they were applying a gram daily for 6 months on the face and neck, and they used an applicator to measure this out. And then they were doing a bunch of blood tests as well. And in this case, they did find that there were no significant differences between the estradiol and FSH levels between pre-treatment and final volumes, but prolactin was increased in the estradiol and estriol groups. So what does that tell you, Kylie?
Well, I mean, prolactin is a hormone that's, responsible for encouraging lactation, and it can be responsive to estrogen. So it means that there are some central effects if they aren't enough to be appreciable from like an FSH standpoint. And I think you would have to do a prospective randomized trial for years to try to see if this affects endometrial cancer. I mean, you could do endometrial biopsies. Those are invasive and painful. And I don't know that they're worth the risk for this, for what's essentially, cosmetic concern, and it's a rare outcome. So it would be really hard to truly understand if this could affect rates of estrogen mediated cancer. But it sounds like generally the risk isn't crazy high from a biologic standpoint in a short term look at it, which is surprising to me. I mean, on the one hand, we prescribe vaginal estrogen all the time. We often prescribe like 2 grams vaginally twice weekly as a standard dosing that people will use. So that's 4 times maybe what people would be generally putting on their face. And it's on a mucous membrane, which should be more absorbent than keratinized skin, the normal skin on your outside of your body. So, I guess it isn't surprising to me that it isn't that impactful and it isn't absorbed that much. But, I do worry about people going crazy with it and putting it on a much bigger surface area or using a much bigger amount.
Yeah, I mean, I think that's sort of the takeaway as well here, that these studies suggest that there isn't a significant systemic absorption of this estrogen when it's applied to your face, and it does help with the way that the skin appears. So there's decreased wrinkles, there's increased moisture retention of the skin. And in this second study, they actually also did biopsies pre and post. And they did find that there was increased type 3 collagen in the post group. So so there's things happening. The estrogen receptors in the skin are being stimulated, and there's increased collagen, there's increased fibroblasts, there's increased moisture, and probably decreased itch as well if you have an itchy face, I guess.
Yeah, I mean,
so there were some. Yeah.
It's a relatively cheap old drug, so I mean, if you're looking for something that can help from a cosmetic standpoint, this is on the less expensive side.
So, in terms of side effects, there were some side effects which I think are important to know about if you're counseling patients on using topical estrogen. So, one, there was some increased reddening in one patient, and there is an increased risk of hyperpigmentation, like melasma being an estrogen hormonally sensitive darkening of the skin, especially around the eyes. There is a theoretical
You can get dark
risk.
spots, basically,
Exactly.
right?
There's a
And
theoretical
probably
risk that
photosensitivity.
if you're predisposed to developing melasma, this can make your melasma worse. So this might not be the best thing for you. Ultimately, this paper was recommending the estriol because it's biologically weaker. So I guess, and
Yeah,
as
that
you were
makes sense.
saying, like maybe it's safer than the estradiol
Yeah, that makes a lot of sense.
potentially.
And it sounds like it worked a little bit better, which is so
It
interesting.
sounds it sounds like it works a
Yeah.
little bit better. And then, since that time, since the 90s, we've had a few papers that have looked at this. There was one that looked at estradiol alongside glycolic acid that found improvement in the way the skin looked as well. So I think the takeaway here is that risk of systemic absorption is low, but it is definitely still possible, depending on how much you're applying potentially, but there are improvements in the way the skin looks. So there is increased hydration of the skin, increased thickness of the skin, decreased visibility of fine lines on the face.
So would you recommend it? I'm curious.
Okay, so this is my take on topical estrogen. If you already have a pretty solid regimen of taking care of your face. So you're wearing sunscreen because when we think about aging of the skin, there's extrinsic aging, which is going to contribute to the vast majority of aging, and that's going to be from UV exposure. So you want to have a good skincare routine that includes a solid SPF. Usually I recommend at least SPF 30, and you're going to be applying it to your face whenever you're outside. So you need that. And if you have a solid regimen that usually includes tretinoin, like we have a lot of data backing the safety and the efficacy of topical tretinoin in the decrease of fine wrinkles and hyperpigmentation and skin roughness. So if you already have a solid regimen and you're looking for something more and you are estrogen deficient, so this is not going to work in people who are like 20 years old, who are ovulating regularly, who are producing estrogen via their ovaries. This is for perimenopausal, postmenopausal patients. So that's the caveat. You already have a solid skin routine. You're doing sunscreen. You're doing tretinoin if you can tolerate it. And then you're like, I want a little bit extra. I have prescribed it to a handful of patients.
Makes sense. Yeah, and the other thing, I feel like if you're on an estrogen replacement patch, you're getting systemic estrogen. I'm not sure how helpful this would be, right? Like if you're postmenopausal and you're doing transdermal estrogen, which is very different in patch form, that's formulated to be absorbed versus a cream that's not really supposed to be, that's not designed for absorption of the hormone, then probably
that's also a good point too. And I feel like some of the limitations of this study, obviously there's no control. Like we're not just using vehicle. There were a bunch of later papers that did do that, and they did not find any difference.
Okay.
So there was a paper.
So if they had prescribed this, a cream without the estriol in it versus the estriol, it's not totally clear there would be a difference.
It's I think, are we going to have more data looking at this? I don't know. I think these are relatively strong papers, but again, there's no blinded control where a person is just doing a good skincare routine. And this paper was not really strong on that front in terms of like, what else are they putting on their face? Are they using sunscreen? Are they using tretinoin? What kind of cleanser are they using? We don't know. So we didn't control for any of that.
Mm-hmm.
So it's hard
and I
to
feel
really
like in these studies, the devil is really in the comparison.
it's always like that. It's like, well, I can't really say they didn't control for these other things that people are doing. And we know they're doing other things. One of the papers I did look at did control for that, and they did not really find a tremendous difference. So,
all right. So
I think it's worth trying.
Maybe helpful. Yeah.
I think if you try it, so in this paper, they found clinical improvement was seen in between 7 and 20 weeks. So if you're using, in both the estradiol and the estriol group, if you're using this and it's been like 5 months and you're like, I don't really think this is making a difference, then maybe it's not working for you.
Yeah.
But again, this is a conversation you should have with your physician because this is a prescription. And I know there's a lot of these online derm prescription websites that are offering this now as part of their anti-aging package.
Yes.
Like I think Muesli is Muesli, right? One of them. And so it's out there, but just be informed.
Yeah. And know that and especially if you're a person who has a history of an estrogen mediated cancer, then this is something that you may want to really stay away from.
Yeah, so you want to talk about it with your oncologist if you do have a history of some kind of cancer, and see if they think it's appropriate.
Yeah, makes sense. All right.
But I don't use it. Maybe I should. I will one day, I think.
I don't. I mean, I feel like, yeah. It's something to consider, but I'm not running out to get a tube. I don't think at this point.
Not yet. I do definitely use tretinoin. Tretinoin.
Well,
I love Botox. Probably need like some laser too. It's coming.
Well, great segue. Because the article of the month, or the article of the podcast, I guess, we don't know how frequently we're doing this, is an article that is hot off the presses in 2025. And the article is in the Journal of Sexual Medicine. And it's called Photobiomodulation Therapy for the Treatment of Vulvar Pain Among Those with Provoked Vestibulodynia, a randomized controlled trial. And so this is a trial of an energy source applied to the vulva in order to treat vestibulodynia. And for people who don't know, vestibulodynia is a term that isn't super specific. Odyne was the Greek goddess of pain. So an odynia always means pain. And vestibule is just this area of the vulva just outside the opening of the vagina, which is an area where there is often sexual pain. It can be provoked pain, meaning pain only when it's touched, or unprovoked pain, so just pain at rest. And so the authors of this paper were trying to determine if they applied this energy source to the vulva, if it improved people's pain. And so I'm curious, so I know from you that you guys in dermatology will use this light source for other applications. So maybe you could give us some background on the energy source they're using.
Yeah, so in dermatology, there's been an increasing trend toward using this low-level laser therapy, so LLT, for the treatment of various skin conditions ranging from acne, aging, hair loss. And the data out there is pretty reasonable in terms of it working. The way that it works is there is a photon that's emitted from a light-emitting diode, and it's absorbed by chromophores and photoreceptors or acceptors in the cellular tissues. That absorption interacts with the skin cell, the keratinocyte, or the deeper skin cell in the dermis. So I think this can penetrate about
5 millimeters. I think.
In that paper we looked at, it said 5 millimeters. So it interacts with the skin cell and it changes the way the skin cell functions. It can increase the synthesis of these reactive oxygen species and adenosine triphosphate in cell tissues. There's also release of nitric oxide, and ultimately this causes the regeneration of collagen, increased production of elastin proteins, a fibroblast production, and then that improves the look of fine lines and wrinkles, and also in hair loss stimulates the hair bulb to grow and retain the hair within it as well as to grow. That's kind of what we use it for.
It sounds like it's basically like causing beneficial chemicals to be released in the skin that make things like better elasticity and pliability and regeneration. Does that seem like a real character? Okay.
That's the gist of it.
Yeah.
In skin and hair, generally the wavelength is in the red light and near infrared light range. So that is 633 and 830 nanometers. So that's a wavelength we are looking for in what we are using it for. These are the ones that you can kind of buy over the counter. I think you can get different wavelengths if you're going to see a physician in the clinic. Typically, when I have patients who have hair loss and they are not getting as much hair growth as they would like to see with things like topical minoxidil, oral finasteride, I will say, you could try a low-level light therapy and see if that works. And then the ones that you buy, like the kind of hair helmet,
I wonder
in that range. And I think those do provide some benefit to hair growth. The downside is that they are pretty pricey, and that the product that you choose really, I think these have FDA clearance, but there's going to be a lot of variability, so you have to really look at the specifications to see if they are in the wavelength that you're looking at. Like how long is the treatment session, etc. So I feel like that's very personal, and then is it in your price range? But yeah, we do use this. I mean, probably don't recommend it to every patient that walks into the room, but it can add a little bit of oomph to like what you're already doing.
Okay. Yeah. Okay. So that's fair. So then that brings us to what they did in this study, which is use
Yeah.
similar light therapy or, energy therapy. And they applied it to the vulva. They applied it both to the like external vulva and near the vestibule and also to the sacrum because the roots of the nerves that come from the vulva go through the sacrum. I think I'm not as impressed by how that may have helped because this penetration is only about 5 millimeters in the tissue and those nerves tend to be deeper. So, and they said that is one of the limitations. Like they're not really sure that following along the path of the nerve that far will help. And so they had people do a number of sessions along of this therapy, along with some mindfulness and meditation techniques and education about pain in general in this area. And then what they found were the outcomes essentially they did have these patients that had the real therapy. So I think the strength of the study is that they had a sham. So people didn't necessarily know what they were getting. And it was a pretty good sham, meaning a fake probe, right? So half of the people got the real therapy and half of the people got the fake therapy. And I think the fake probe must have been pretty convincing because half of the people who got the fake one thought they got the real one. And about half of the people who got the real one thought they didn't get the real one. So it's pretty convincing that people didn't know what they got in terms of their therapy, which is a marker of a good placebo. And so it sounds like they had some benefit, decreased pain on exam, decrease in a questionnaire about pain, but it doesn't seem like it really translated to change in sexual function. And I think that's the tricky part. It sounds like for other derm applications, it does translate to a change in function, but I was just not so convinced. It feels like to me that when it's a pain condition, you have to reach there's a much higher threshold for efficacy. Like if you reduce someone's pain, sexual pain for 20 or 30%, I think they said in one of the quantities they cited was about a 30% reduction. It's not enough. You're only as comfortable as your most painful area. And it's not a substantial enough reduction is what I thought. Maybe it could be part of a multimodal therapy, but I don't think it's like the end all be all. And I don't think, for the expense and sort of limited access, I'm not sure it's the most worthwhile thing to pursue.
Yeah, it did seem like their protocol was fairly difficult. And I know they kind of print out what the difference. It just seemed like it would be difficult to do on your own, and it seemed like more of something that somebody did for you.
Yeah,
just because of how complicated it was. And there was a fair amount of, I thought, loss or attrition of the study population because it was a little more intense than people were hoping for it to be.
Yeah, 15 sessions is a big commitment.
It's huge.
I mean, we have a hard time with 6 sessions.
Like each of the sessions were like an hour long. It's like 45 minutes, right? I mean, So the nice thing about most of the times that we use LLLT in derm is like you do like a 10-minute session or a 20-minute session like 3 times a week.
Yeah.
And it's not like you have to go in and do it. You can do it on your own and still reap some benefit. Like maybe going in and the whole act of like being cared for and all that probably makes you feel a little better. So maybe that contributes to it as well. And I don't think they really controlled for that because they had a lot of other things that they did in addition to the laser. In addition to the light, right? They had like an education session and there was a lot of other things going on.
But I think that they have equal interventions in both groups. So I think that cancels out, but I still think
you're right. They both got it, but maybe that was what was helping patients anyway.
Yeah. So. I think it just at the end it didn't translate to change in like sexual outcomes in this term.
So there was a reduction in vulvar pain, but there was no reduction in one
of the other instruments that they measured that really is looking at like function.
Okay, and so there were no changes in the psychological outcomes and sexual function between the real and sham groups.
Yeah. And so I think to me, like you may improve in terms of how we touch, like, we do this Q-tip test where we touch the vestibule and see where the pain is. And maybe you're more tolerant of the Q-tip test or you can tolerate a little bit more pressure. But if that doesn't translate to difference in sexual function, it's just not as meaningful. So again, if you had access and unlimited time, maybe it would be part of a multimodal strategy to help a patient, but it's certainly not first line. Is my take on.
Yeah. Again, and I think this goes a lot of the things we look at. I think people are looking for like a silver bullet. for a lot
Yeah.
of the diseases that we treat, so like lichen sclerosis or vulvodynia. But in the end, it comes down to there is no silver bullet here. It is multimodal with different approaches from different angles to improve the whole
Yeah.
you, right? I mean, I feel like, and this, like, if they had an easier way of applying this, if this was like a home device that you could do on your own, like that.
And I guess too, you have to think about it in the context of the fact that for vestibulodynia, if we've removed hormonal issues, right, we've optimized patients, like if they need topical hormones, we've given them to them. And we've tried, other nerve activating medicines like topical gabapentin or amitriptyline, and patients aren't getting better. Our tools are limited, and often we'll talk to those patients about removal of the vestibule, which is a surgery that's really morbid and last line. So, I mean, I guess trying this is it's a low risk intervention compared to a surgery that can cause, a nerve issue or an issue with lubrication long term. But I think it doesn't have the data isn't as good for efficacy. We know the surgery is like pretty well tolerated, and most people get a significant reduction in pain if they have pain limited to the vestibule that we think is more neurologic in origin.
Were you surprised by this little patient demographic data where they had listed the things that patients had tried? I mean, I was just kind of like, well, I don't know. I was kind of perplexed.
I may have missed that table.
Let's see. Using like NSAIDs or like
which it's really interesting because I was just at Ishwish and there's probably NSAIDs may be more harmful not more harmful than helpful, but they may while they may cause a decrease in prostaglandins that cause pain, the substance that cause pain in the tissue, they also probably decrease the substances in the tissue that can sort of like bring back homeostasis and normal neurologic activity. So it's kind of a double-edged thing with NSAIDs. But yeah, so okay, in terms of what they had tried, I mean, that looks like that looks like a list of things our patients would have tried. We don't usually use and they're talking about systemic progesterone. Their age range,
they're 27, but for both plus or minus.
Yeah. So, I mean, topical estrogen makes a lot of sense to me. We definitely have patients that do get better on topical amitriptyline, but the data isn't great. And, so, I mean, I think, and the other thing is they had a lot of people, a fair number of people who are on hormonal contraceptives, and they don't say more specifically what those are. If they're on something with phenyl estradiol that they're taking systemically, the estrogen that's in both birth control pills, then that can have a substantial effect on the vestibule. So, was pretty even in both groups, but I'd rather see people not on it at all in a trial like this.
Yeah, and I wonder, it says use of medications for PVD. So are they using hormonal contraceptive for PVD? I mean, it's just kind of a weird.
Which is not something we'd recommend, but you never. Yeah, so I guess the take home is probably not harmful, but not really going to make a huge change in terms of sexual function.
Yeah.
All right. So last segment is where we usually talk about something that we've gotten through social media. And because we talked about labial puffing, I thought we had a really interesting question about that segment from last time. And I thought I would just read it, if that's okay. So a patient said, we talked about labial puffing, which is injection of like filler type medications to increase the size of the labia majora. And we said, it's a cosmetic thing. There are some risks to it. Certainly something you should undertake cautiously. And the patient said, I have very small inner and outer labia due to lichen sclerosis, a skin condition that can cause resorption of the tissue. She says her LS is in good control now, and she uses topical estrogen and testosterone to help the tissue, but she's sort of maxed out on that therapy. And she wonders if fat grafting or filler to the labia majora would help protect her inner labia minora from skin tears. She feels like she's just generally sitting on a hard plastic bike seat, whereas before she had more of a cushy foam seat because of the volume of her labia majora. I'm interjecting here, so this isn't exactly what she said. And then she said she's aching and soreness, and even with her LS fairly managed, she's still prone to tearing. Would this be a person for whom you would consider restoration of the outer labia with some kind of filler to protect the tissue? So I'm really interested to hear what you think about this.
So I think the first question I would have is whether this person's LS is actually well controlled. When I hear about recurrent fissures, tearing in the labia, it makes me concerned that there's something going on. So before anything, that would be the first thing I would do. I wouldn't jump to just doing filler in the labia. And the question of, is there a contact dermatitis?
Yeah.
Is there too much steroid being used? Do we need some kind of non-steroidal? Lots of things cross my mind when I hear that.
Yeah, and I wondered about things like Candida because obviously if you're putting steroids for, LS, then you may have some other, super tough time clearing Candida from the skin or tinea. And then the other thing I worry about when I hear that in someone who's complaining of pain when they're sitting is, do they have epidental neuralgia? Like the fissures are one thing, and that's obviously a skin condition issue, but also do they have a neuropathy that hasn't been recognized that we need to address as well?
Also, I don't really use topical testosterone for.
Same, I don't. I mean, sometimes we'll use it in combination with estrogen
Yeah.
at the vestibule, but that's not really tissue that's often, I mean, it can be affected in LS, but usually isn't.
Totally.
Usually it's more the labia minora
Again,
and
I think
majora.
labial puffing in the setting of decreased estrogen, menopause, etc., and filling the labia makes you feel good about the way your labia look. I say go for it, knowing that the risks are an injection site reaction. There's some potential vascular compromise that can happen theoretically, but very unlikely. That it's a cosmetic thing. And we talked about this before. This is not a functional thing. The data suggesting that this is somehow functional is just non-existent. And I think whatever we have is like anecdotal anyway from that.
Makes sense to me.
I think so. I think we should talk about testosterone
I agree.
next time because there's like where to look. And I'm sure there was so much about it at the Ishwish
Yeah,
conference.
that sounds great.
Thanks for listening. We really love talking to you all about vulvas. Drop any comments, suggestions, feedback. We really appreciate it.
Yay, thank
And
you.
yeah, until next time.